So today, Dr. Scholz, we're talking about testosterone replacement therapy. Now, there's a massive amount of ads for, what they consider TRT, they call it that, all over the internet. In fact, some ads get put on our YouTube videos. And so I thought we would talk about testosterone replacement therapy with prostate cancer, because there's the concept that, of course, men would like to take testosterone, but does testosterone grow cancer? How do you work through these two complexities? And so, first of all, what is testosterone replacement therapy?
Well, there's a couple reasons that men may be deficient in testosterone. One is just age. And another is that we give medicines to treat prostate cancer, injections, Lupron, Firmagon, Trelstar, Eligard, that suppress testosterone, and they're very effective anti-cancer maneuvers. But they can cause lingering effects when they're stopped. And especially in elderly men that have been treated for long periods of time, a good percentage of them are not fully recovering the normal testosterone levels that they may have had prior to treatment. Use of testosterone is popular, as you've pointed out. It can give people more energy, more libido, improve concentration skills, endurance, and build muscle, which is really important in aging people. So it's a trade-off. Are the dangers for prostate cancer patients greater than the benefits of restoring these things that we would really enjoy having?
So does testosterone itself grow cancer?
Studies show that testosterone doesn't cause cancer or necessarily grow cancer. Cancer will grow on its own. Prostate cancer is unique because it requires testosterone to exist just the way our bodies require oxygen to exist. So if we bathe ourselves in more oxygen, we don't grow taller or bigger, but without oxygen, we die. And that's the way it works with prostate cancer cells. They have to have some testosterone present or they can't even exist. That's how powerful testosterone removal is. It doesn't impede prostate cancer growth. It actually kills prostate cancer cells when we deprive them of testosterone.
Making sure that I have this clear, it's not that testosterone is growing the cancer, it's that the process or the existence of testosterone allows for prostate cancer to happen.
Yes, that is correct. It's all rooted in, think of young boys going through puberty. Prior to the advent of puberty, when they have low testosterone levels, the prostate is just a vestigial little nub in the size of your little fingernail. And then when they hit puberty and testosterone comes on, then the prostate gland starts to expand into its normal dimensions, they say like the size of a walnut, and make semen. And so testosterone is the stimulus for the prostate to form or even exist. And the same capacity or the same need is carried over if a prostate cell becomes cancerous, then it needs to have testosterone to continue to exist.
I just wanted to take a quick second to ask you to donate to PCRI. All of the videos that we create are sponsored completely by viewers like you, and you can help our cause in an incredible way. You can visit pcri.org to donate, and you can visit the link in the description below. Thank you so much, and now back to this video on testosterone replacement therapy. You mentioned the benefits of testosterone. What are the things that happen when testosterone is taken out of the body?
Well, the ramifications are great, especially in aging men, because the number one thing we get concerned about is loss of muscle. And as people are getting older, they're already losing muscle. And loss of muscle causes weakness. And if you think of looking at someone who you say, that person looks elderly, you're really looking at them and saying they look weak. And the weakness can be rooted in the loss of muscle. So testosterone blockade can cause very rapid and severe muscle loss. And it is, in theory, reversible, but it takes a lot of work to reverse it. If people allow their muscles to become atrophied when they have low testosterone levels, building them back up can take several years of concentrated effort. So the loss of muscle is a very serious potential side effect of testosterone blockade. It can be avoided with strength training, but it has to be very rigorous and consistent strength training to maintain muscles when your testosterone is low.
One of the questions I've gotten from patients is, when we talk about strength training, when someone is on hormone therapy, they're wondering, is it possible to keep 100% of your muscle mass? Is it a certain percentage that I'm looking for? Because I think some patients get kind of frustrated that they don't see the gains that they would like.
When people are in a testosterone-deprived state, we're trying to just hold on to what they already have. It's pretty difficult to build more muscle, although certain very dedicated individuals have accomplished that. It has mostly to do with how rigorous and how consistent the weight training is. But for people that go to the gym 3 times a week and work out all their muscles in a very thorough fashion, they can maintain 80 to 90% of their muscle mass while their testosterone is low.
I've had a lot of patients comment that the expectation that they would do weight training on top of feeling so fatigued and dealing with cancer already is a huge feat. But I think that something you've mentioned that has been really helpful is getting an actual trainer if you can afford it. And if not, maybe doing a virtual one or classes or something on YouTube. There's a lot of resources out there. But I think that that's very important for motivation if you're going to go through that process, because it's incredibly difficult to do.
It is. I mean, we all know it's a good thing, and we would have been doing it already throughout our lifetimes if it was an easy thing to do. And getting professional help, some sort of supervision or accountability can make a big difference. And for men that are embarking upon testosterone deprivation therapy, it needs to be taken very seriously. The duration of the low testosterone varies depending on the different types of prostate cancer cases, but especially for men that are going to be in a testosterone-deprived state for more than 6 months to a year, getting a trainer makes a lot of sense.
Another benefit from that is the fact that they'll be able to handle further treatments a lot better because they have the muscle mass and the strength in order to do it. And it helps with, your physique, your emotional levels. It's a big deal. So I know it's definitely a difficult thing to do, but so worthwhile. So with that being said, you have people that, are going to be wondering, okay, well, if, when you, at the beginning of the video, you mentioned that there are 2 ways we lose testosterone, age and then being on hormone therapy. What will happen if somebody takes testosterone replacement therapy after hormone therapy?
People have often stated to me that they're fearful of using testosterone because they think of it fueling the cancer. It's not just patients, but also professionals, other physicians have raised that concern. It turns out that in the prostate cancer realm, this concept has been very thoroughly tested. There have been thousands of volunteers who've participated in studies where men with low testosterone who have had prostate cancer or still have prostate cancer are randomized between groups that stay off testosterone therapy and compared to a group that takes testosterone, so-called intermittent therapy. The testosterone that they're taking may be merely stopping the lupron and allowing normal testosterone to return, or it may be men that actually receive testosterone to restore normal levels. It's the same testosterone, whether it comes from the testicles or through a shot or through a cream that you rub on your skin. If done professionally under supervision, the PSAs could rise, and if the testosterone replacement is stopped in a timely fashion before the PSA goes too high, say above 5 or 10, just to pick a number, these men do equally well. These studies run out to 10 years, showing that the incidence of hormone resistance or cancer progression or even mortality from prostate cancer is no different in the men that get continuous low testosterone therapy, testosterone deprivation, compared to those that are allowed to have testosterone back intermittently. It's not just that people thought this idea is something to consider. There's actually large clinical trials that show that it can be done safely.
So what does the timeline look like for monitoring? If you have been off of hormone therapy for a certain amount of time, how long is that time before you can start taking testosterone replacement therapy?
Well, the way we think about it is in increments. If you look at the studies that have been done to demonstrate the efficacy of testosterone deprivation, for instance, with intermediate risk prostate cancer, we'll give 4 to 6 months of testosterone deprivation with Lupron. With high risk prostate cancer, we'll give 18 to 24 months of testosterone deprivation therapy. So if people have completed that interval and their testosterone after stopping treatment is not recovering, that's when we may start a discussion about the possibility of taking some testosterone. And it's not mandated that testosterone must be restored to normal levels. It's a quality of life decision. Some men feel perfectly fine with low testosterone levels, and they don't really see much of any motivation to have their testosterone levels restored. You have to be monitored more carefully, and of course there may be some expense involved and more doctor visits to administer testosterone. And they're thinking, I feel fine already. These are usually individuals that are on a regular exercise program, and they're not looking to recover their libido or their sex lives, and that's perfectly fine. However, there are other people that are looking to gain perhaps more energy and libido and would be interested in pursuing that possibility. The idea, of course, is that we want people to fulfill the initial treatment period that is thought to be appropriate for their level of risk. So for intermediate risk, 4 to 6 months of low testosterone. For high risk, 18 to 24 months of low testosterone.
You had mentioned that the patients who are on hormone therapy, needed to have completed whatever course was necessary in order to go on testosterone replacement therapy. Is there like a 3-month wait, a 6-month wait where you look at the PSA and make sure that the hormone therapy worked and that they can come off of it before you would start TRT?
Yes, actually, although there's certainly no prescribed rules that have been developed. But our policy has been to allow men some time to recover their own testosterone, because quality of life is better if you don't have to give yourself a shot or a cream every day. And so we'll typically give about 6 months for the body to recover spontaneously. But if after that time period things are not coming back to what we would hope or expect, then we start talking about maybe giving some testosterone.
Is there a safe dose that patients should pay attention to if they've been on hormone therapy? Is there a doctor who's going to prescribe it? What does that look like?
Well, the dosing is sort of, I won't say fixed, but if it's a cream, there's a suggested starting dose. If it's a shot, there's a suggested starting dose. I would mention that the focus needs to be on how people feel much more than the actual number in the bloodstream. In fact, we started off with that already. If people are running low testosterone but feel well, leave well enough alone. But if people are feeling deficient in energy or a libido and want to try and restore these things, let's try some testosterone. And once the testosterone is implemented, we continue to ask that same question. Are we solving the tiredness or the loss of libido problem? And we focus on that much more than a specific number of getting the testosterone to 300 or 600 or 800. And it's been very hard for patients and even physicians to kind of unwind that, let's see what the blood is, make the blood right, because it grabs everyone's attention, but it doesn't correlate really well with how people feel. So some men with higher testosterone still feel tired for who knows what reasons. Other men with somewhat lowish testosterone, say 250 to 300, feel great. The professional societies, there are experts that have written about how to give testosterone to men with deficient levels, are very strong in counseling that it's how people feel much more than what the number is in the blood.
One of the things you've mentioned in previous videos that I found very helpful from my understanding is the difference between potency and libido. And I've heard patients talk about not really knowing the difference, and when they're taking TRT, not really knowing what to expect. So can you define that a bit?
Yes, there's a lot of confusion about that. And it is important to make a distinction, because some men believe that by taking testosterone, they're going to improve their ability to get normal erections, which is what we call potency. But the studies have shown that just testosterone alone doesn't really have much of an impact. We have to pursue other means such as Viagra or Cialis injections or whatnot to try and restore normal erections. Libido, it has to do with the mental reality of attraction to being involved in sexual activity. That urge or interest level is what we call libido. People without a libido are probably not interested in pursuing erections, but studies have shown that men can get erections with low libido even while on Lupron if they take Viagra or Cialis. So there is a disconnect between libido and potency, and people shouldn't be pursuing testosterone replacement if they think they're going to further enhance their ability to get erections. That's unlikely to happen.
Another thing I've seen you mention is the concept that you're checking testosterone. Now, I've heard from patients all around the country that they've been on hormone therapy and maybe the doctor hasn't been checking the testosterone levels, but the PSA. Should every patient who's on hormone therapy also get their testosterone checked?
I suppose at least once. There are rare cases of people who've taken Lupron and other agents that it wasn't effective. And so we do want to confirm that the testosterone is low at some point. We don't have to keep checking it in whom people it's already established that their testosterone is low. But we usually check the testosterone at least once in men that have that are on therapy to make sure that they're getting a complete and normal response to the testosterone deprivation therapy.
So let's talk about possible adverse effects. So, I've heard that there's the possibility of blood clots. So how do you check hemoglobin? What is the monitoring process? And what's also the timeline for that monitoring process?
Why people are often concerned about the testosterone replacement exciting prostate cancer. As a physician administering testosterone, I'm more concerned about the possibility of the body making too much blood, we call it polycythemia, the opposite of anemia, and creating thicker blood, which predisposes men to blood clots and heart attacks. And this is a well-known phenomenon that occurs with testosterone replacement therapy. There are ways to counteract it, but it's not something that you would want to miss through failure to check blood counts, so-called CBC or hematocrit blood counts, to make sure that the red cells are not becoming excessive. The hematocrit should remain under 50% in men who are taking testosterone, and it's not at all uncommon for the levels to rise above 50%, and then that signals the possibility or a greater risk of blood clots, heart attacks, strokes, really serious ramifications. And so that can be counteracted by men donating blood or reducing the dosage of their testosterone replacement therapy. But it does need to be monitored closely. So we'll typically check a CBC after about 6 to 8 weeks of testosterone replacement. We'll check it every 3 months for the first year. And if men are maintaining stable hematocrits, less than 50%, throughout that time period, then we can just check it maybe twice a year. But it does need to be monitored, and it's a far more important issue than the PSA, which, of course, everyone's going to monitor that as well, and everyone's aware of the fact that there's prostate cancer in the background. But prostate cancer-related things happen very slowly. Stroke, cardiovascular things happen suddenly and potentially irreversibly. So the hematocrit needs to be followed with great care.
Today we talked about testosterone replacement therapy. The reason I'm bringing this up is, number one, a lot of you have asked, what are the ins and outs of testosterone replacement therapy and how does it affect prostate cancer? But the other reason is PCRI has a massive focus on quality of life. So I want you to know that there is the possibility that you can get your testosterone back and what the safe procedures are in doing so. Please remember that all of the conversations that you see here with Dr. Scholz, you should go talk to your medical team and you should talk to your doctors and ask about these things and see if there are options for you and really engage with that concept. How is my energy levels? What can I do? Do I need to start weightlifting? Or what do I need to monitor in order to take testosterone replacement therapy? The concept is number one, there's always hope that the situation you're currently in, if you're struggling with it, can change. And the second thing is that your quality of life matters. How you walk through this prostate cancer journey is extremely important. Please remember we're a 501c3 nonprofit, so if you'd like to donate and join our cause in correcting misinformation about prostate cancer and also getting the news of all this education out to patients all around the world, you can donate at pcri.org. All right, well, as always, please remember, you're not alone. I hope you have a great week and much love to you.